Okay, let's dive right into this explainer. Today, we're going to explore the incredibly complex web of how healthcare systems actually decide who gets care and why. It's an absolute balancing act. Every single day, public health officials and doctors have to make really tough decisions about where resources go. And to understand how they do that, we have to look closely at the relationship between three fundamental concepts: need, demand, and supply.
You know what's really interesting? Former Oasis frontman Liam Gallagher actually perfectly illustrates how needing care and getting care aren't always the same thing. Even though he suffered from severe arthritis and clearly needed a double hip replacement, he admitted in an interview that he hesitated. Why? Because of the perceived stigma of getting a quote-unquote hip-hop as a rock star. He represents a super common phenomenon, a patient who is literally in pain, but intentionally avoids entering the healthcare system.
So, that brings us to a really foundational question. If someone is in pain, like Liam Gallagher, why might they not seek help? And on the flip side, when millions of people do seek help, how does the system figure out who to prioritize? In a world where healthcare resources are, quite simply, finite, understanding this dynamic is the absolute key to seeing how our medical systems function behind the scenes.
To entangle all this, we're going to hit 5 core areas in this explainer. First, the Healthcare Balancing Act. Then, Bradshaw's taxonomy of need. Third, what happens when systems get unbalanced? Fourth, why does imbalance happen? And finally, health needs assessment.
All right, let's move right into part 2, Bradshaw's taxonomy of need.
Back in 1972, a researcher named Jonathan Bradshaw created a framework to define what need actually is. He pointed out that the whole history of social services is really just the story of recognizing needs and then organizing society to meet them. So we start with the patient's perspective. First up is felt need, which is completely subjective. It's just a patient-defined want, like saying, "Man, I have this bad pain in my hip and I just want it to go away." But here's the thing. A felt need doesn't always interact with the healthcare system. It only becomes an express need when that internal want turns into a vocalized request. It's the moment you actually pick up the phone, book an appointment, and say, "Doc, can you do something about this pain?"
But experts, they look at this from a completely different angle. They deal in what's called normative need. This is when a professional assesses the patient and determines, yes, they have a condition, but more importantly, an effective intervention is actually available to treat it. And finally, there's comparative need, which is all about equity. Think about it like this. If population A has a hip replacement rate of 10 per 1,000 people, and population B is super similar but has a way lower rate, then population B has a comparative need.
This friction right here sits at the very heart of healthcare. A patient's desperate desire for relief, their felt need, doesn't automatically mean the medical system has a viable, cost-effective treatment ready to go, a normative need. Just feeling sick doesn't trigger a systemic action unless the experts agree there's a proven, effective way to actually help you.
Which brings us to part 3, when systems get unbalanced. What happens when these different definitions of need collide on a massive population-wide scale?
Well, you have to remember that in an epidemiological sense, just being in poor health isn't defined as a need. Crazy, right? Need strictly equals the capacity to benefit from a healthcare intervention. Demand is the expressed need of the patients, which is sometimes mediated by doctors. And supply, that's just the healthcare that is actually provided and available on the ground.
Now, if you picture this as a Venn diagram, the absolute sweet spot is right in the center, where need, demand, and supply all perfectly overlap. That's a met need. But look at the outer edges. When demand and supply overlap, but there's no actual need, we are literally wasting resources on unnecessary services. And even more tragically, when need exists but it falls outside of supply and demand, we end up with a vast pool of completely unmet need.
This dynamic creates what epidemiologists call the clinical iceberg. The healthcare system only sees the tiny tip of the iceberg poking above the water. That's the known disease, the expressed demand, and the normative need. But lurking way below the surface is a massive amount of unknown disease. This is the felt need that gets ignored, asymptomatic conditions or patients who just don't come forward.
All right, part 4. Why does imbalance happen? Let's dive into why this really delicate balance between need, demand, and supply is constantly shifting and, let's be honest, frequently breaking.
Well, we're dealing with a massive demographic 1-2 punch here. First off, as population projections clearly show, we are living way longer. Life expectancy has jumped dramatically since the mid-20th century. But as we age, we don't just get one illness, we accumulate a compounding number of comorbidities.
By the time someone hits their 80s, the vast majority are managing multiple complex health conditions all at once, which drastically drives up the overall need.
But hey, it's not just age. Changing expectations and a rapid medical progress are shifting demand too. Let's look at hip replacements again. Because the prosthetics are incredibly durable now and the surgery is way less grueling, patients just aren't willing to wait until they're 70 or 80. This massive shift in confidence and patient expectation actually drove a 76% rise in hip replacement operations for people under 60 in just a single decade.
Culture and professional awareness heavily drive demand and shape need as well. Take endometriosis, for example. Historically, a really poor understanding of the condition and a culture of basically dismissing women's pain has led to a staggering global average of 7 years just to get a diagnosis. This represents a massive systemic unmet need driven entirely by a lack of professional and public awareness.
Now, even if we perfectly identify the need and the patient demand is super clear, we still run smack into supply constraints. The actual supply of healthcare is strictly bottlenecked by hard limits on public expenditure and severe workforce shortages. This creates a reality where healthcare literally must be rationed. And this rationing happens in two main ways: implicitly by just making patients wait in long queues, or explicitly by setting strict funding thresholds that intentionally limit or deny care for certain treatments.
So let's hit our final section, Part 5, Health Needs Assessment. How do public health officials actually try to fix this imbalance? How on earth do they decide what to fund and what to cut? Well, they use a tool called a health needs assessment, which relies heavily on evidence-based medicine. Before offering any treatment, they measure 3 specific things. First, efficacy. Does the treatment work in perfect, ideal, controlled circumstances? Second, effectiveness. Does it actually do more good than harm in the real world, under usual hospital conditions? And third, cost-effectiveness. What's the health gain per unit of cost? They measure this using something called a QALY, or Quality Adjusted Life Year. To put that into perspective, total hip replacements are a perfect success story of this assessment process. At age 60, the surgery gives a patient about 7 additional high-quality life years. The cost comes out to roughly £7,200 per QALY. And since the UK's National Institute for Health and Care Excellence, NICE, sets their threshold between £20,000 and £30,000 per QALY, hip replacements easily make the cut. This makes them a really high-priority supply for an aging population. Ultimately, the goal of an epidemiological health needs assessment is to constantly pull those 3 circles back into perfect alignment. We want to identify and reduce the core need, we want to realign patient demand through better education, and we absolutely want to perfectly match our medical supply to the true remaining need. Which leaves us with a pretty big, provocative thought to take away from this explainer. We know for a fact that healthcare resources are finite. So as we push forward into an era of aging populations and incredibly expensive new medical technologies, how do we guarantee that our medical systems are serving that silent, unseen need floating right beneath the surface of the iceberg and not just catering to the loudest, most expressed demand? It's a truly delicate balance, and one that is absolutely going to define the future of global healthcare.